So we've created this center called CHIPS, which is the Center for Healthcare Improvement and Patient Safety. We're now in the process of eliminating all these classes of infections. We use this perfecting patient care methodology. We're using it across every unit. You know, the surgeons are not exceptions to this. Sorry, they're not exceptions to this. They have to be engaged. So now I want to just conclude in the last 10 minutes a little bit about the cost of this. Because at the end of the day, when I was in Pittsburgh, people said, Dr. Shannon, that's great humanitarian work, but what's the economics of this? It is the world in which we live, and please don't just dismiss that. Until you can unravel in the minds of your CEOs this issue, and you have an enlightened leadership, the true impact of this is not known. So what's the cost of the central line infection in terms of human and financial terms? What does society pay for hospital-acquired infections? And do hospitals and doctors actually make money on hospital-acquired infections? 3 questions that we sought to answer. So let me begin with my vignette. 37-year-old video program director, father of 4, came to the emergency room in Pittsburgh with acute pancreatitis secondary to hypertriglyceridemia. So on day 3, he developed hypotension and respiratory failure due to what we thought was very severe pancreatitis. On day 6, he developed fevers with positive blood cultures for methicillin-resistant Staph aureus that was attributable to a femoral venous catheter that had been in place for 4 days. The guy developed multiple intra-abdominal abscesses as a result of the systemic bacteremia, had to undergo 4 laparoscopic drainage procedures of those, developed renal failure as a result of the hypotension and became dialysis dependent, couldn't be weaned from the ventilator at day 24 and underwent a tracheostomy, and 86 days after this human being came to my unit to get care, he went to a nursing home. Now, he was eventually weaned from the ventilator, but still had his trach and is dialysis dependent to this day. Now, you can talk about 5.1 infections per 1,000 line days, or you can tell the stories and be honest with yourself about the consequences of this work. Honest with yourself as a leader. You can't look at the unit and say, it's their fault. You, the leader, must take responsibility for this travesty. Now, I know you'll all sit there and say, boy, this Allegheny General Hospital must be a horrible place. Horrible place. Look, go look. Free yourself of the delusion and go look. So what's this cost? This was an extremely important exercise. I'm sorry that the numbers got a little screwed up. But we got paid $200,000 from this guy's insurer for this 86-day hospitalization. When we did activity-based cost accounting just on this case, it cost us $241,000 to deliver the care. So while we got paid a lot of money, it cost us more. We actually lost $41,000 on that case alone. Now, the CFO kind of in these organizations, I'm sure in yours, have these sixth sense. They can tell when there's a sucking noise like $41,000. They have this intuitive sense. They have no idea where it is. But what they do is things like, you know, change the laundry vendor or cut the cafeteria hours or, you know, decrease the number of times we change the linen, all that stuff that has nothing to do with why you're losing money. Secondly, because there are more than one case of pancreatitis, when you roll this individual loss up into the whole DRG, nobody really sees it. It's only when you dissect it out that you say, my God, $41,000 is a lot of money. Now, what would we get paid if we did it right? So we found 3 cases of acute pancreatitis just like this guy, where we got paid $5,900 for doing it right. It cost $5,700. The hospital made a cool $119 when we did it right and the patient went home in 4 days, but healthy. So what if some of that got moved over there and we actually paid for the outcome as opposed to paying for this? Now, I also want to illustrate that's Allegheny General Hospital's problem, that's society's problem. Because instead of paying $5,900 for this case, or instead of paying $99,000 if it was like needed a Whipple procedure for God's sake, we paid $200,000. We, you and me. You know, we have this notion that the government pays for health insurance. No, they don't. You pay for health insurance. You pay for health insurance because you and your employers pay for health insurance. That means they don't pay you wages because they got to pay for that benefit. It's simple. It's not the government. It's us. You paid me that. We have to stop with this notion. It's us. It's us, the healthcare community, that's spending it, and it's us that's paying for it. I don't have time to talk about the perversion of the insurance system, but let's just say the thoughts crossed my mind that this won't work in the long term. When we looked at 54 central line infections, we got paid $64,000 on average for these cases. For the central line infection cases it cost us $91,000 worth of care. We were losing on average, just as Ed said, about $26,000 on every case that was complicated by a central line infection. Sure, we thought we were getting paid a lot, but it was costing us a lot. And then, you know what? Our finances were in two different buckets. The costs were over here, the revenues were over here. And until you brought them together around this case, no one knew that. That meant that in my 26-bed ICU, central line infections contributed to a $1.4 million operating loss, reduction in margin. In only 4 cases did we actually make any money. The additional cost of care, what Carolyn was talking about, what Medicare is going to take away, was 43% of the total cost. So back 43% out of this number, and that's what you're going to get paid. So your losses will only go up. The average length of stay was 28 days for patients whose care was complicated by central line infection, and the range was 7 to 137 days. And only 3 human beings of the 54 went home. Meaning that 19 of them died and the rest were in a nursing home. So the meter is still running, not on your dime, but to society and to the $2.5 trillion we spend on healthcare, that's the cost. So is it possible to do away with this? Yes. Is it sustainable? Not until leaders commit to working with workers. Is it worth it? Please raise your hand if you'd like to get one. Now that's where I like to see no hands raised. We lose a substantial amount in every CLAB, and the loss is fully attributable to the central line infection. So we did the same thing around ventilator-associated pneumonias. I want to take a minute to do this. So the interesting thing about this work is once the nurses and the unit culture changed around central line infection, taking on ventilator-associated pneumonias and methicillin became natural. It took 1/4 of the time to get people up to speed on this because they had learned what this was about. So the average payment we got for a ventilator-associated pneumonia was $62,000. The average cost was $87,000. We're actually losing $24,000 on every ventilator-associated pneumonia. That was a $2.4 million loss from operations in a 26-bed ICU. Every year I'd go to the budget meeting and the chief financial officer said to me, boy, this ICU is losing money. We're going to have to cut the number of nurses per bed, or we're going to have to not fill the respiratory technician position. All this stuff. All we had to do was do this. And I'll show you that in a minute. The average payment for a ventilator-associated pneumonia, $62,000, was nearly twice what we got paid when we actually ventilated a patient properly. The average length of stay was twice for ventilator-associated pneumonias, and 32 of the patients that got a ventilator-associated pneumonia died, and 43% of them had a tracheostomy. Wonderful outcome. So here's what happened with ventilator-associated pneumonias. You saw a significant decline in the first year. Now here was the issue. We were losing $24,000 on each ventilator-associated pneumonia. We actually discovered that even in patients who didn't get pneumonia, we were losing money when they were ventilated. Why? Because we had no weaning protocols. And why didn't we have any weaning protocols? Because we had this notion that the only person that could change the ventilator setting was the house officer. Now, we heard this morning about the life of a house officer, right? Incredibly chaotic, all over the lot. And let's just see, maybe 3 years of experience, right? Maybe 3, if it's a resident, senior resident. Who's got the most experience on how to work the ventilator? The respiratory therapist.
Thank you.
So, what fundamental principle of society would collapse if we actually asked the respiratory therapists to do their job, to do what they're trained to do, and didn't have to get permission to do it? What we would do in the mornings, we'd write weaning orders. And then we'd say, decrease the positive pressure to X, and decrease the rate to Y. And then we'd disappear. And 20 minutes into the wean, the guy would, get a little anxious, and the heart rate would go up, the blood pressure would go up, the nurse would say, oh my God, call the intern, and the intern would say, oh, just put him back on the other settings. That's why you didn't wean anybody. But if you said to the respiratory therapist, hey, can you go look at that? They say, oh, I figure out what's going on, let's suction them, let's check the pressures. Unbelievable. Unbelievable. Now, this is what the hospital lost, okay? This is the situation with what doctors were getting paid. So when doctors took care of ventilated patients in my ICU, they on average got about $3,200. When they took care of patients that got a ventilator-associated pneumonia, they got paid more. So as I started to eliminate these infections, one smart pulmonologist came up to me and said, "Excuse me, we need to have a conversation. What about the economics of this?" So this was a very difficult moment. The only way we could solve this problem was that when we did away with ventilator-associated pneumonia, which was the right thing to do, and the doctors clearly recognized it was the right thing to do, they were just worried about their income. We admitted 126 more patients to those same ICU beds. And guess what? Those of you that are doctors in the room, that first day of billing is usually the big day of billing, right? So an admission really counts for a lot more than continuous care. So not only did the pulmonologists not lose revenue, they actually made more money by collaborating with us in eliminating ventilator-associated pneumonias.